Good afternoon, everyone, and welcome to this first afternoon session. My name is Amel Ghouila. I'm a Senior Program Officer, Data Science Ecosystem at the Bill and Melinda Gates Foundation, and it's my pleasure to be chairing this first session for this afternoon. So we heard a lot, data, data, data. Here we are. This is the data science session, and we're going to be following on the theme of this conference about sharing approaches and methods to better support health research in every healthcare setting, with a focus on data and how data could contribute to these objectives. And we will be covering during these sessions data from different perspectives and how using data could inform and guide evidence and policy on the ground. I'm pretty excited about this session, bringing different perspectives, different skill set, and people working at different angles of the research and health delivery ecosystem. So to kick us off, I'm going to invite my colleague Bilal Mateen, who is the Clinical Technology Lead, Data for Science and Health at the Wellcome Trust, to give some opening remarks. Bilal?
So what I want to do in the next few minutes is two things. First, reflect on what inequity in data science-related research means to me. And the second is share with you a little bit about why we're so excited about this recent grant that we've made to the Global Health Network, Latin America and the Caribbean. Glad I've got Trudy in my eye line. I'll be back for you, Trudy. Starting with that first one. What does inequity in data science-related research mean to me? So those of you that have heard us, or myself, my colleagues from the Wellcome Trust, talk about our work, you'll have heard this line that we like to use. The nature of science is changing. It's becoming increasingly more computational. The opportunities afforded by using larger, more complicated data sets that require specialist software, hardware, analytical skills are becoming more evident day by day. And the trend that we've seen over the last decade is that these opportunities are becoming consolidated in a small number of institutions, often in high-income countries, which I'm sure you can all agree is profoundly problematic. And the example I like to use, it's a crude one, that demonstrates why I think it's so problematic, starts with a really simple question. How do you end up with a racist computer vision algorithm? Anyone in this room that has ever been part of a software development project will know that the first group that you test your alpha product on is yourself and your team. If you get to beta testing, it's your friends and your family. So how do you end up with a racist computer vision algorithm like Google did, like Twitter did, like so many research groups have? You have a team that's not representative of the community at large. It's not profound. We spend a lot of time thinking about and talking about how we need more representative data sets to address inequity in health research. I think that's necessary, but it's not sufficient because we have a more foundational problem. It's the fact that those opportunities aren't available to everyone to have a seat at the table where the research is being done. And that's how we end up with inequitable research. We need more people from more diverse backgrounds in the room where the research is happening and being a part of it. And that's what makes me so excited about the grant that we've made to the Global Health Network, Latin America and the Caribbean, because it's a very intentional commitment to the tune of about £8 million from the Wellcome Trust to try and make sure that Latin American voices are heard and have a seat at the table. And a large part of that award is going to be around data science related capacity building and capability strengthening. And I could wax lyrical about all the small things that we've done along the way that change how we made that grant. So the money isn't going via a single host organization, it's going directly to our LAC partners. But instead, what I want to do in the last 58 seconds that I have is say thank you to someone. And that one individual is Trudy Lang, because over the last year, she demonstrated what I can only describe as an almost pathological level of perseverance in I want to say, a number of conversations I lost count of, telling us not only how we can do better as a funder, making sure that we understood what good looked like, but also helping us get to a place where we could make this grant by making a whole series of sacrifices herself. And we're here, the grant is made. And that's what I want you to take away, right? From that sort of reflections and from that little anecdote about Trudy, that the solutions to inequitable research, whether they are data-driven or not, is about individual actions. It's about people like Trudy. It's about people like all of you in this room going the extra mile to make sure you're using the right data set, that is representative, that you are inviting in colleagues and local partners so that we can make sure their voices are heard, and taking that extra, let's say, year of your life to tell a funder how to do their job, right? Because we're willing to listen. I'm not going to take up any more of your time. We've got 6 incredible people on stage who I want to hand over to. So Amel, I'm going to give the microphone back to you. Thank you very much.
Okay, so thank you very much to the organizers for the invitation to speak here today. I've been really interested in hearing data come up so many times because that's what I do. So I'm going to talk about a number of things. I don't think it's probably not important to go back to the data needs and challenges, but I'll just highlight a few. And then I'm going to talk about 3 ways that we've been trying to address the capacity development in terms of data. And I'll talk firstly about H3A because that was really the pillar for how everything else kind of came about. And then the data science, a new consortium we have, and then how we've been working in the public health space. So if you think about the different data types for health, so you have the research space where you have the clinical data, you have demographic data, and then you generate some observations or some experiments, omics data, for example. Perhaps you bring in climate data, environmental data, and then in the health space, you also have routine data that's being collected all the time. And between these two, there's often a big disconnect between these two because access requirements for the different data sets are different. How they've been curated, how the data has been collected is often very different. And when you want to do data science and make novel discoveries, you have to do a lot of data linkages, you have to do a lot of data integration, and this is really, really tortuous. But that is absolutely required in order to actually to apply data science techniques and then make novel discoveries. So there are challenges in every single piece of these whatever I've got on the slide. So every piece of the data, the metadata, curation of metadata, bringing the data together. In Africa, it's even about moving the data, storing the data. So you have to think, obviously, the other components of this, the study design, consents, the management analysis, and then the training, obviously, and the capacity development for every one of these pieces is where we've been focusing. So the first project is the Human Hereditary and Health in Africa. So H3 Africa is a consortium, it's an initiative that was funded by the NIH and the Wellcome Trust, then via AISA and now via the Science for Africa Foundation. And the aim was to facilitate modern contemporary research that looks at the genetic and environmental basis for diseases on the continent. So it's a number of cohorts that are collecting data for studying very different diseases. But underlying the research and the science is a very strong capacity development and network development goal or role of this. So H3 Africa generated a lot of data. So we're in like 10 years into H3 Africa. We've got phenotype data, we've got genomics data, we've got other kinds of omics data, we've got process data, GWAS analyses, etc. And we have this now, if you look across the different the projects, we've got data for more than 100,000 participants. This is probably the biggest collection of data on the African continent, given the previous scarcity of African data. So this came up with, brought along a lot of data-related needs. So bioinformatics requirements for computing and network infrastructure, data management support, analysis support, etc. And then underpinning all of this, of course, is training. So H3A is the bioinformatics network that was set up to deal with all of these bioinformatics needs of the consortium. So our network has been running, it started up with 32 partners. In the second round, we dropped down to 28 partners, but we spanned 17 different countries and we have more than 200 members. And the aim has been to build data-related skills to empower African scientists to take ownership of their own data, their own publications. So we've had to play a role in all aspects of the genomics. I mean, our focus here has been particularly genomics, but it's really applicable to multiple omics or other areas. So in the whole workflow of a genomics experiment, we've had to build things like the data infrastructure. So the data transfer protocols, we took 3 months to move a data set from the US to Cape Town. Now that sets you back 3 months before anybody else, if anybody else has access to that data, you're already 3 months behind them. So we had to set up good data transfer protocols, security, obviously, because it's human data, build data standards, and all the other infrastructure. And then, of course, the data-related skills. So I'll just talk a little bit about some of those that we've tackled in H3A. So data transfer protocols, we've evaluated a number of different mechanisms, and we've gone with Globus Online, and we now facilitate transfer all across the continent in the, being cognizant of the electricity cuts and the poor internet. And then we've also put in a compute infrastructure for storage and analysis across multiple centers in Africa. So when we started 10 years ago, there were just a few small pockets of institutions that could actually do even small-scale genomics research. They couldn't even get to medium or large-scale genomics research. Now we have a number of centers that really can tackle, a few hundred genomes, maybe even 1,000 genomes, whole genome sequencing, and big, 10, 20,000 genotyping array GWAS. We built an archive for genomics data, so we are the data submission system for submission to public repositories. So we always make sure that the data are shared responsibly, and they have to be shared globally, but with the African researchers getting that extra time to analyze and exploit the data, so that there's, and also when you share the data, to try to encourage benefit sharing and collaboration with the original data owners. We've developed a whole lot of containerized workflows that are feasible in the African continent. Not everybody, in fact, very few people in Africa use the cloud. So we've developed containerized workflows that can be deployed on systems that are relevant to African settings. And in all of those, we've developed training. So we run hackathons for the developing of workflows, and we train sysadmins to actually manage this compute infrastructure, because your normal university IT infrastructure, they don't necessarily work with, like buggy bioinformatics software. We built a lot of data standards as well, because it's really important in data science to make sure that the data are collected in a standardized way. So we've built standard case report forms for many different diseases, and we've done a lot of training in REDCap and data harmonization. But a very big component, as I've mentioned previously, is our human capacity development. And in H3BioNet, we've had to tackle that in using very different approaches. So we run hackathons for really goal-driven outcomes, whether it's an analysis of a big data set, or it's developing workflows, or it's developing a new tool or a platform. We've had to deal with the demand not only for training our own bioinformaticians and the clinicians and scientists within H3 Africa to use their own data, but also to address the enormous demand for bioinformatics and data science skills on the continent. So we run these big online courses, of a flagship introduction to bioinformatics course, and now more intermediate courses. And in order to make sure there's long-term sustainability for this, we've built a train the trainer program as well. So we try to focus on developing foundational data-related skills and then applied skills. So the foundational skills being programming, statistics, GitHub, HPC, and then the applied skills will be in 16S microanalysis or GWAS or NGS analysis. And in order to reach a much wider group, we've introduced this remote classroom model, and it's been so popular that we've taught the Wellcome Connecting Science how to do it, and many people around the world are trying to adopt this model. So basically, we have local classrooms across the continent. Before COVID, they were face-to-face, and during COVID, they just went online. We're going back to face-to-face again, and they were all connected two times a week for 3 months on a particular course. All the training, coordination, the lectures, and everything is managed centrally, and these classrooms, sometimes up to 50 classrooms, connect twice a week to the lecturer and to each other. And through this, we've managed to train in our IBT, our Introduction to Bioinformatics course, we train up to 1,000 people at a time, 50 classrooms across the continent. We've been running this for 6 years, and literally we finish one course and we get the requests for the next course to run. And now we've gone to the more advanced training where you can actually run major workflows on HPCs or on the cloud. And those are sort of about 20 classrooms and about 400 people. But this has really enabled us to increase our impact. So we've managed to train a number of different trainers. We teamed up with the carpentries to do some training, the bioinformatics, the clinician and scientist users, bioinformatics scientists, bioinformatics engineers who are going to be developing, the next generation of tools, and then sysadmins to make sure all the underlying infrastructure is in place. Because remember, when you're sitting in the global north, all that is in place already. In the global south, you've got to do it yourself. It's just not there. So overall, we've trained more than 4,300 people on the continent, and we're just continuing to do that, and the demand is just never ending. So because we've built this massive infrastructure for training, we then were able to leverage this for the new consortium, which started about a year ago. So the NIH are basically funding this new initiative called Harnessing Data Science for Health Discovery and Innovation in Africa, otherwise known as DSI Africa. So this consortium has a number of research hubs, training grants for degree programs, LC projects, and then a big open data science platform. That's Alwazi, and that's the one that I'm leading, the open data science platform. But these research hubs are tackling, they had to use existing data sets and have multiple different data types to answer a research question in health and get to a health benefit. So that it has to be reasonably translational. And so the data types are extremely diverse, from climate to environmental to clinical to omics data. It's very diverse data types, images, etc. And so we've had to sort of move out of our comfort zone of genomics and think about data models for all these different data types and how to bring this together, how to harmonize across these, and particularly the linkage and the data integration and then application of data science tools for a real health benefit. So the infrastructure development has been the open data science platform, which I'll talk a bit about, but there's also an engagement component, building these big networks of data science for health across the continent, and then human capacity development, again, the basic data science skills. So the Alwazi platform, this is the infrastructure that allows the data sets to come together and be analyzed, with data science techniques and on various different cloud computing platforms. So all the different projects from these research hubs bring in their data, and we've also looked outside of the consortium. We've got much interest from other groups as well. You have your data sets sitting either on local HPCs or on various cloud buckets. They are all indexed in the platform. The platform has a registry of all these data sets. There's a registry of tools, and there's access to various cloud computing infrastructures, GCP, Azure, AWS, on-premise solutions. You log into a workspace, that's the Alwazi workspace. It's currently running through Terra at the Broad Institute. You identify the data sets that you want, you pull out the data, you identify the tools that are in a common repository, completely open access, and then you choose which environment you want to run in. And so you can actually run this in a collaborative way. And we are making sure that this is feasible for the African setting, not for the US setting, not for the British setting, but for African researchers who have local infrastructural challenges. So another big component of this obviously is data science training. So the data science grants themselves, they are degree programs. So they're starting brand new degree programs in data science related to health, all around particular topic areas. So they all have particular disease areas or machine learning for imaging, etc. And then as a consortium, we're working on developing data science competencies. Data science, specifically data science for health. Data science is huge. We're looking specifically data science for the biomedical sciences and thinking about the competencies you need in order to apply data science across multiple, very diverse data sets. So we're busy doing that, and we're mapping these to the degree curricula. And now, as we're in H3 Barnet, we've got our flagship Introduction to Bioinformatics course that runs across the continent. We're going to be developing a flagship Introduction to Data Science for Biomedical Sciences that can run across the continent in an equal way, reaching up to between 400 and 1,000 participants. We also focus on training fellows to develop the next generation of research leaders. We do this in a number of different ways. We give specific professional development to our fellows, but we also get them involved in our working groups. We put them in co-leadership positions. They learn from osmosis and learn from the managers and really build their skills. And we've seen people go from postdoc to full senior lecturer positions and associate professor positions in the span of H3 Barnet. And then finally, the last initiative I'll just talk briefly about is the public health training. So again, the infrastructure we built in H3 Barnet was perfect. It was a perfect springboard to be able to apply this to the public health setting. We started this work actually just before COVID started. So really, we were ready to get up and running and do a lot of training on SARS. And the components there are to build a training curriculum. We've rolled our training in SARS-CoV-2 for wet lab and bioinformaticians. We've run some foundational courses in bioinformatics for public health and also in containers and workflows so that they can develop their own tools. We are working on a standardized curriculum for the Africa CDC so that they can make sure that when they start a new public health institute, that each institute knows what skills they need to have and then have access to the training materials for that. So we're working with the public health institutes across Africa that are linked to the Africa CDC to build a standardized curriculum and then roll this out or have all the materials available. And then for stakeholder engagement, we've, as I'm sure many of you have seen, there's been an enormous need for long-term support after training. You can't just train people and then leave, because they still need further support. They need further mentorship. So we've actually developed a trainer database where trainers, global trainers come in, they put in the area of expertise, and then that's linked to a help desk where trainees can come in after any course, anytime, anywhere, ask a question with a category, and then that category also automatically links them to the trainer. And it's all anonymous, so you don't have to worry about your email address getting out. And then there's sort of an organic, question answer, global connection of trainers and trainees. And so the aim is to build, these trainee communities and trainer communities. So the take-home messages is that over this time, we've built significant capacity for bioinformatics and data-related skills on the continent. These have all been through funded networks. Funding brings people together. If you don't have any money, you need serious will. But we've managed to bring people together. We need to think about how to sustain this long-term. So we're looking at a potential African Bioinformatics Institute or African Data Science Institute, which can then be applied to anything outside of health as well, because these skills are applied to everybody. So with that, I'd just like to acknowledge the various consortia that I belong to and the funding from the Bill and Melinda Gates Foundation for the public health training and the NIH for the other two consortia. Thank you.
Thank you very much, Nikki, for this great talk. I think we can have time for 2 questions. There are questions from the audience for Nikki. Yes, we can start here. If you can move forward a little bit so that you can get the microphone quickly, that would be great.
Thank you. So my question is to Nicola. So I was wondering, has the H3A Bionet been doing any work related to undoing the culture of male biology-oriented research through its work in data science capacity building? Because I see a lot of potential there. Thank
So
you.
you related to?
Related to undoing the culture of male biology-oriented research.
So we have, so a few of us, including Amel, we're women in data science ambassadors. So we promote, women in data science. We have a specific symposia on that. And we have a group that, so some of our people have been working with, it's a group at Sanger who also have been working in women in data science. There are a number of initiatives. There's the, I can't remember what the name is, but it's, R, women in R, and women in biostatistics, and women in programming. And so we work a lot with those different groups to promote women. Actually, our greatest shining stars in H3A Bionet have been women, and particularly in Muslim countries, actually, which has been amazing. So we've got some amazing people from Tunisia, from Sudan. Amel was in H3A Bionet for many years. And so we've seen a lot of women rise through the ranks and they get into these leadership positions.
That's great news. I was also mostly wondering about gender inclusive data.
Oh, the data.
Yes.
So we don't, because we are in the kind of the next step, we help people to work with the data. We don't have any control over what the data is. So the data comes to us when it's already generated. So we can't tell the research projects, you need to do this. But in Asia Africa, there's a very strong, awareness of gender balance in the data. But as I say, as we get the data after the fact, so it's not like we can maybe change that.
Thank you.
We have time for one more question, if there's a question in the audience. I'll use my chair privilege here to ask a question, another question to Nikki. Curious to hear a little bit about how do you connect the different stakeholders and disciplines. You run trainings for public health institutions, training for academic institutions. Curious to hear a little bit more about how do you help connecting the dots?
So we actually find that reasonably difficult because there are very different audiences. And they do have different priorities. But in the SARS group that we've been working with, it is quite a big mix of academia and public health. Because I think, as you've seen from the previous talks, is a definite need for both. So when we've run training courses, we've had both audiences in there, and we've tried to get them connected. And first, particularly in South Africa, they are very well connected because we have a network that covers both when SARS came along. So H3 has been traditionally academic focused, and obviously this one's public health, but we've recognized that we need to connect them a bit more. And some of the courses, as I say, do have both.
Great, thanks. Thank you very much, Nikki.
All right, good afternoon, everyone. Thank you very much to the conference organizers for this opportunity. So today, as Amel mentioned, I'll be presenting my research team's work, how we use real-world data to measure primary healthcare quality and its effects on maternal and child health in Brazil. So primary healthcare is a pillar of any universal health system and a determinant of maternal and child health outcomes. At the Center for Data and Knowledge Integration for Health, Cidacs in Brazil, we do pioneering research using real-world data from millions of Brazilians. Where am I supposed to point this? To create population-based cohorts. So we study, among other things, how public policies impact the population's health. In specific, my research group was using an innovative approach to evaluate the relationship between primary healthcare components and under-5 mortality in Brazil. So the objective of this work was to describe the utilization of real-world data to explore the relationship between the quality of primary healthcare components and under-5 mortality in Brazil. So it's an experience report of how we integrated different administrative databases to use or reuse real-world data to understand how PHC interventions impact maternal and child health outcomes. So we created an anonymized database linking a series of government databases, which are the Live Births Information System, the Mortality Information System, the Unified Registry of Social Programs, known as the Cadastro Único in Brazil, which provides socioeconomic information on over 130 million individuals who apply to any social benefit program. Also, we use the database from the National Primary Healthcare Access and Quality Improvement Program, which characterizes the structure and work processes of primary healthcare teams. And finally, we use the Bolsa Familia program conditionalities database, which details at which primary healthcare facility are Bolsa Familia beneficiaries, which is Bolsa Familia is a conditional cash transfer program. So where they comply with their cash transfer conditionality, so where they receive their primary healthcare. Okay, so as you see in the figure, we joined several databases and ended up with a population of 143,000 children, which by Cidacs standards is actually quite small because we used to work with databases of millions. And these children, but still it's a significant population. So these children were all born in 2010. And they were attended by 12,085 primary healthcare teams across 3,601 Brazilian municipalities. We created a theoretical model of determinants of under-5 mortality, specifically 10 PHC components and some proximal determinants that represented individual socioeconomic and biological characteristics. These are determinants that we know affect under-5 mortality. So what we tried to do with our primary healthcare model is to open up the PHC black box and decipher its relationship with under-5 mortality. In doing so, we identified 5 PHC building blocks, which represent the foundation necessary to be able to deliver primary healthcare services. And these were reference and regulation system, planning and organization of work processes, facility infrastructure, general supplies, and workforce. So the quality of these building blocks affects the quality of maternal and child health services, which we identify as the most important being antenatal care, the quality of antenatal care, child care, and immunization, bearing in mind that this is a quality of the infrastructure for immunization rather than immunization coverage. Our proximal determinants were birth weight as a proxy of biological characteristics and mother's education as a proxy of socioeconomic characteristics. We also included antenatal care utilization variable to mediate the effect of antenatal care quality. So the conclusion with related to the usage of real-world data is that it enables innovative approaches to assess the impact of primary healthcare quality on maternal and child health outcomes. And these strategies allow an agile and robust scientific production capable of uncovering scientific evidence in unprecedented proportions, quickly and with low costs. Some challenges we encountered were specifically in terms of methodologies we could use to analyze our data, as we were assessing simultaneously the effect of various components of primary healthcare, limited the methodologies we could use, as there's not many methodologies that allow to study multiple exposures at the same time. Also, under 5 mortality, fortunately, is a rare health outcome in Brazil, even in our cohort of millions. So this implied further methodological limitations. And the nature of our data was dichotomous, so it also limited our choice of methodology. However, we managed to pull through, and we realized that it is possible to measure clearly and concretely the quality of primary healthcare. We have a series of very clear and concrete variables that joint into indicators, and these indicators form our components that I presented. This PHC model that we developed can be applied to study the impact of primary healthcare on other outcomes, also less rare outcomes. And also recognition to our statistics team, because they studied a lot to adjust existing methodologies to be able to measure our exposures and their impact on under 5 mortality. And they really did some pioneering work. So I know we're only supposed to speak about the processes, but just bring a bit more detail about the research project per se. We did a literature review and an expert consultation to develop our PHC components. We used Bayesian confirmatory factor analysis to measure the quality of our primary healthcare components on a continuous scale. We use multi-level Bayesian path analysis to measure the impact of the PHC components on under 5 mortality. And finally, we used predictive modeling to obtain more concrete estimates of the effect of better PHC quality on predicted under 5 mortality. And I'm going to bring a little spoiler of our study results and some recommendations for policymakers based on them. So we found that improving the quality of planning and organization of work processes can decrease under 5 mortality by almost 6% by increasing the quality of childcare services. This was the greatest effect that we found among what we identified as our PHC building blocks. Improving all of our PHC building blocks, however, all of them at the same time, can decrease under 5 mortality by almost 41%, which demonstrates that PHC is greater than the sum of its parts, and we feel that's a very strong message coming from our study. So we recommend policymakers in Brazil to value the development of first-line implementers' capacity for planning and organization of PHC services. And for policymakers in other low and middle income countries, they can try and adapt our PHC model to their context to try and measure primary healthcare quality and understand in their own health systems which primary healthcare components should be prioritized. That's it.
Thank you, Amel, for the introduction. I'm Durga, I'm from India, and I'm in my last year of PhD at the University of Warwick, UK. I'm working with Professor Saravanan. So today I would like to talk about our work on using machine learning for the antenatal prediction of postpartum prediabetes in women diagnosed with gestational diabetes in their pregnancy. So gestational diabetes is defined as glucose intolerance first diagnosed during pregnancy. When the mother is diagnosed with GDM in her pregnancy, the mother as well as the baby are predisposed to a lot of short-term as well as long-term complications in the future for the mother as well as the baby. And some of these are listed in the respective bubbles. So a major and a very common complication of GDM for the mother is type 2 diabetes in the future. So the glucose levels rise in the pregnancy due to hormones secreted by the placenta. And usually these again come back to normal levels when the mother delivers the baby. However, in some cases, when the normal functioning doesn't doesn't happen. The mother still has high levels of glucose in the postpartum weeks. And this is when she is termed to have prediabetes, and then she is at higher risk of developing type 2 diabetes in the future. So just some statistics, around 90% of GDM is concentrated in low and middle income countries. And these GDM women are at 10 to 12 times higher risk of developing type 2 diabetes as compared to normal women, in spite of having such high disease burden in the low and middle income countries. The follow-up rate is very low. So if you if you see the follow-up rate in high-income countries of about 60% in the UK, what would you expect in low and middle income countries, right? It's much lesser than that. You would be surprised it's practically 0% also in some places. So we developed this study with the vision to develop precision model in order to improve the quality of life of two individuals in one go, the mother as well as the baby, and in turn help to prevent the intergenerational propagation of diabetes. So specifically for this study, the objective was to develop a prediction model. So the story is very simple in 3 steps. First is to develop the prediction model for antenatal prediction of postpartum prediabetes. Second is identify the woman with high risk of developing postpartum prediabetes using the model. And third is to achieve targeted follow-up of this high-risk group in the future. So even after the mother delivers the baby. So it's a very simple and straightforward story. Now, how do we achieve this? So the methods can be divided into 2 broad parts. So part A is develop the prediction model. And secondly, which is, I think, the most important part, especially for the low and middle income countries, is to select the optimal cutoff for stratifying these women based on their risk of developing prediabetes in the postpartum. Depending upon the resource availability in that particular setting. So we used the KL divergence and information theory from the formal mathematics to develop the optimal cutoffs. Now we had 607 women recruited, however, only 394 turned up for the postpartum screening. So the machine learning experts in this room would obviously raise questions. The 394 is a very small sample size to train a good machine learning model. So this was the biggest challenge that we faced to train a good machine learning model with such small amount of data. And we had to develop the framework in such a way that we use maximum data, so the data that we had as effectively as possible. Usually machine learning divides the data into 2 parts, training and testing. But then we lose the testing portion for training and training portion for testing, right? So the novel idea of this framework is that we used the entire available data for training as well as the same entire available data for testing without letting any part of the testing set see the training data, which is the central dogma of machine learning. And we do this using the nested cross-validation concept. So there are 2 cross-validations running one inside the other. The outer one is for evaluating the model, and the inner one is for tuning the hyperparameters of the algorithm. So there's a very nice saying that better data beats fancier algorithms. So we focused on improving the quality of the data that we used for training. And we used a very simple algorithm of logistic regression in order to maximize the interpretability of our developed model. So the key ideas of the methods step by step are: first, identify the features with maximum predictive ability. In this process, we can create new features if possible and if they are meaningful biologically. Then develop a prediction model using an effective model architecture. Fourth is representing the model mathematically if possible. So maybe develop a composite risk score using the logistic regression algorithm. Study the optimal thresholds to stratify the women based on their risk. And finally, all of this we can translate to a simple tool that the clinicians can use in the real world setting. We had our share of challenges in this process, and I would like to share some of them as this is the main target of this conference. So first and the foremost, so we had very small data, as I told before, and this is a big concern in all prediction models, model development work in the health science domain. So even if data is collected, sharing the data becomes difficult because of ethics and data privacy related issues. So both of these concerns can be, can be solved for by using the novel ideas of deep learning and generative adversarial networks to generate data synthetically. And then we can either augment the synthetically generated data to the real world data to increase the sample size, or completely replace the real world data with synthetic data to account for the data privacy issue. Data incompleteness, so there was less follow-up, failure to have 100% follow-up, and missing values and the existing collected data, which can be solved for using a targeted follow-up approach, which I talked about through the entire presentation. And there was data imbalance, so very less representation of the positive class, so it becomes difficult to train good machine learning models without bias for the positive class, for the negative class. So but then these can be addressed using technical things like smooth and so this is the last slide where I'll show the interface of the postpartum prediabetes prediction that we developed using only two features, antenatal fasting glucose and antenatal HbA1c. And you can see in the first case, the woman has a low risk with only 0.09% probability. And the second one with 5.8 fasting glucose and 40, we can easily predict that she has high risk of having postpartum prediabetes. So the clinicians can use this effectively in the real world setting. So these are my acknowledgements, and thank you very much.
Thank you. Thank you. I'm Ephraim, and I'm a nurse from Ghana. And I'm here to share with you secondary data analysis from the recent Ghana Martina survey, which was in 2017 on socioeconomic factors associated with adolescent pregnancy and motherhood. Adolescent pregnancy is a contributing factor to global maternal mortality rates as a result of unsafe abortion practices among these adolescents. In Ghana, approximately 40% adolescents between 15 to 90 years had childbearing, and adolescent pregnancy contributes to approximately 9% of maternal mortality in Ghana. The aim of the study was to assess the association of socioeconomic factors with adolescent pregnancy and motherhood in Ghana. And understanding these variables are vital for effective policy formulation in Ghana. 2017 Ghana Maternal Health Survey, which was implemented by the Ghana Statistical Service, was used, and the sampling frame was from 2010 Ghana Mortality and Housing Census. The service sample involved two-stage stratification, and in the inter-stratification stage, 10 regions of Ghana was divided into urban areas and rural areas, which resulted in 20 sample strata. And in the independent selection in each stratum, two stages were involved. At stage one, the sorted the strata generated administrative regions and levels by using indirect stratification and proportional allocation before sample selection. And probability sample technique was used to select 900 enumeration areas, which produced a cluster sample of 466 from the urban areas and 434 from the rural areas. In stage two, random sample was used to select 30 households from each of the 900 cluster, which resulted in 27,000 household sample. And from these, 92.8% were women between 50 to 49 years. Also, women greater than 20 years were 80.9% of them were greater than 20 years. And adolescents between 50 to 90 years made up of 90.1%. Among these adolescents, 40.6 were ever pregnant and 11.8 were ever had live birth. And during the motivate regression analysis, we found that zone of residence, wealth index, marital status, level of education, age were associated with adolescent pregnancy and motherhood. And also adolescent pregnancy and motherhood were higher in the middle and coastal zones, and also among older adolescents. We also found that pregnancy and motherhood was lower among adolescents from households with highest wealth index, those who were never married, and also those who had secondary or higher education. In conclusion, we found that several socioeconomic factors were associated with adolescent pregnancy and motherhood in Ghana, and hence sexual and reproductive health education should be intensified among this population. And also adolescent-friendly corners where they can access reproductive services should be also made available and accessible to all adolescents in Ghana. The process, the process and challenges, how the data was obtained. First, you have to register with the demographic health survey as a data user. And in your cover letter, you have to state the purpose and also emphasis on requested data. You have to emphasize that the requested data will only be used for the purpose of the research study. And also, if you want to use the same data, we have to send a new cover letter. And normally, demographic health survey review all request data within 24 to 48 hours. And they also provide notification if access has been granted or modification is needed. And the challenge from this analysis was it required more analytical skills to make meaning to the data sets. And these are my references, and I want to acknowledge the demographic health survey, the survey participants, all co-authors, the government of Ghana, United States Agency for International Development, the European Union delegation to Ghana, and the United Nations Population Fund. Thank you.
Can you hear me? Yes. Now it's post-lunch, so I have to be a little louder so that everyone is awake. I understand post-lunch sessions are difficult. So I'm going to make it little interesting. Okay. Okay. So the topic I've researched is on the equity in reproductive health care using the healthcare equity transformation model. So when we talk about equity, so there is difference between equity and equality. Equity is like everybody is given the same. Equity is like they give what you want, what you deserve. So I remember the Global Health Network, they're very particular with what you want. So they follow lots of equity. I appreciate it. So when you talk about equity, I found some very interesting thing. There's a definition for equity. It said that there is, in short, equity creates a path from hope to change. I found it very interesting. So equity is something which has to create a path where we think of something, where we hope for something, but equity actually should bring a change. And when we talk about reproductive health equity, it gives people what they need to have a fair chance at sexual and reproductive well-being and autonomy. So this is a place where I work. So these are the tea gardens of Assam where I work. So you see how beautiful they look, but when you look inside, it's quite challenging. The situation is different. This is another part of India. India has a part called Assam, where we find the tea garden people who are at the lowest, for the most vulnerable population who are there. And the objective of my study is to introduce the health equity transformation model in the reproductive healthcare. So we have used a secondary data, and we have used a rapid review to analyze what is the reason for the barriers in the healthcare equity. So NFHS means it's a National Family Health Survey data. It's a large-scale multi-round survey data which is done in the households of India. So we have the 5th round of data which we have analyzed. So the data was connected between 2019 to 2021. It was conducted in 2 phases, and they have covered around 6,36,699 households throughout the country. So when we talk, there were around 7,24,115 women and 1,01,839 men, and providing the key estimates for all the states of India, covering 707 districts.
So when you talk about the sample and the sampling in the NFHs, so they have covered the district into a rural and an urban area, where the rural, they take something called a sample of villages. And in the urban area, they take something called the census enumeration block. And each one is called a primary sampling unit. So each primary sampling unit, they were around 30,456 primary sampling units. And they used a probability systematic sampling, which was a random thing. So when we analyze the data, so what we want to analyze from this NFHS data, we want to analyze two things. One is the equity to access reproductive health services. And the second one is the utilization part, where women, how they utilize the antenatal care, the skill birth attendance, and the family planning. And the equity was measured against the urban-rural area and women's education and the wealth quintiles. So as you see here, this is the data which talks about the education, the wealth quintile, along with the registered pregnancy. So when you see here, the data is very interesting. People register, but when you see the antenatal care, it's high among people who are educated, and it's high among the people in the urban areas, and also among the people who are having a higher wealth. So there are interesting thing is people register, but there are people, the percentage keeps coming down when it comes to people who had more than 4 antenatal checkups. So people register, but people are not compliant. They don't follow up. So this is it. And we all know that it follows a social gradient, where a person from a lower socioeconomic position, their worse is a chance to health. So that is universal everywhere. So we want to find out particularly what are the things which determine for this non-utilization and the equity in the reproductive healthcare services. So we have chosen the health equity transformation model for this. And we have searched 4,107 databases and records, and we found 42 studies which were relevant to our topic. And we found a conceptual framework for the healthcare equity. So there are few interventions, and there is an impact, and what is the outcome. So there are few interventions which are required to achieve this reproductive healthcare equity. The first one is the policy. Second one is there should be accountability. Third one is there should be leadership in governance. Fourth one is collaboration. And the last one is the culture. So the impact is divided into 3 dimensions. The first one is the system. The first one is the socio-economic obstacles, the lack of quality care, and lack of poor infrastructure in India. The next one is the role of family, which is very important. A woman is pregnant, she wants to go for a checkup. It's the family who decides where to go, what to be done, where to deliver. So the role of family, I didn't put the role of mother-in-law, but it's actually the mother-in-law and the husband who takes the lead in India. And also, there are lots of cultural and traditional practices which are prevalent in India, where people say you have to go here for your delivery, we have to go to your mother's place for delivery. So they have lots of things. And the last one is the individual experiences. The first one is a negative experience. Like women sometimes don't want to go to a healthcare provider because they had a negative experience. And the second one is women have priorities in spending. Imagine a poor tea garden woman or any woman who has money. She wants to spend it for the family rather than spend it on health. They don't know the importance of health. So they rather spend it on something which benefits the family, which benefits the children. And the last one is women lack autonomy in their utilization or access to the healthcare services. So when you have these interventions, when you have this impact, I'm sure that it's going to have an outcome, good outcome on the reproductive healthcare equity and utilization. So there were a few challenges. As usual, we have used a secondary data. And when you use a rapid review, it's like we limit our database search, and but still we were able to produce a comprehensive analysis of the factors which are necessary. So there are a few recommendations. The first one is we have to strategically target the social determinants of health, which is my doctoral thesis. This is a part of the study which we have done. And we have to emphasize more on women's education and economic empowerment. And we have to empower the health workers to collaborate more with the community. And we have to address women's social vulnerability as a barrier to utilize reproductive health services. And the last but not the least, we have to address the cultural and religious belief, which provides a tangible first step for all the communities. Thank you.
Thank you. Good afternoon. I'm Christy Mulowoza, a medical doctor. I work as a research coordinator with the Ministry of Health in Uganda in the AIDS control program. Thank you, the organizing committee, for giving me the opportunity to be here today. I'll be talking about assessment of the effects of community differentiated service delivery models on viral load suppression among children and adolescents living with HIV in Uganda. Viral load suppression for children and adolescents living in Uganda improved but remains low at 74% compared to adults, which is 91%. That is according to the District Health Information Software System 2021. This is due to suboptimal ARV regimens, non-adherence to treatment due to psychosocial and drug administration challenges. With support from PEPFAR, Uganda started implementing the community differentiated service delivery models for children greater than 2 years and adolescents 10 to 19 years living with HIV in 2020. The facility-based models, we have the facility-based individual management model, the facility-based groups, the fast-track drug refill, and amongst the community models, we have the community drug distribution point, the community client-led ad distribution. A national DSD dashboard was developed to monitor viral load suppression among clients on DSD models by DSD type. We set to assess the effect of the community DSD models on viral load suppression among children and adolescents living with HIV across the country. We have the processes where the community client-led ad distribution point. This is when a particular group of clients, usually there are 6 in number, and one client goes each month to collect on behalf of the group. And then the community drug distribution point, these are designated points within the community where retroviral drugs are dispersed to persons who are living positively with HIV. We retrospectively analyze data for children and adolescents living with HIV from the DSD dashboard for all HIV ART clinics in Uganda. That was from July to September 2021. And this dashboard pulls data from the DHIS2, the National Reporting System, on a quarterly basis. Descriptive analysis included data on demographics and viral load suppression for community DSD models. 92,562 children and adolescents living with HIV were active on ARTs between July to September 2021. 56.2% were females and 43.3% were males. Amongst the facility-based models, there were 74%, and then we had 21% for the community DSD models, and then 5% were the uncategorized. The uncategorized are usually people who never belong to either of the models. And then amongst the facility-based models, for the facility-based individual management model, we had 28%. The facility-based groups were 45.3%. The FTDR, that was 17.9%. And then amongst the community models, the CDDP was 1.6%, and the CCLAD was 1.5%. Viral load suppression among the community DSD models did not differ by sex. We saw the males were 67% and the females were 66%. And then by the community DSD type, there was also no difference. We saw the CCLAD 62% and the CDDP was 61%. So from there we concluded among children, viral load suppression, that is less than 1,000 copies per mil, was 62%, and 75% among adolescents living with HIV were receiving ART under the community DSD model. We observed a lower viral load suppression for children and a comparable viral load suppression for the adolescents in the community DSD models compared to the national viral load suppression. However, there's no significant difference in the viral load suppression among the two community DSD models. Children and adolescents living with HIV can still benefit from the community DSD models. However, psychosocial support should be strengthened, especially for children. Some of the challenges were delayed viral load testing. This was mainly observed, especially for the CCLAD clients, whereby some of them would go to the facility and at times they'll miss out having the viral load testing done. There's also poor documentation, and this is evidenced in those who are in the uncategorized, whereby we all know they belong to a certain model, but somehow it was not documented. And then the poor patient literacy, where some of the patients didn't know which models they belong to, despite being on ART for a very long time. Special thanks go to the PEPFAR through the CDC for their support in making this happen. Thank you.
This was an amazing panel, and I'll try to summarize a little bit, but I know we won't do justice to all these amazing talks. So we talked about the importance of data science skills, how skills evolve, and the need of developing infrastructure and analysis workflows that are adapted to the context. Then we saw some amazing exemplars of data reuse, leveraging different types of data, primary healthcare data, routinely collected data, national and household surveys to answer different types of research questions, look at efficiency of health service delivery, thinking about the use of therapeutics, personalized medicines, measuring inequalities and targeting interventions, improving healthcare services, to inform policies and guide interventions on the ground. It also struck me that we have different backgrounds represented here. It was really great to hear from some experiences from frontline healthcare workers, leveraging data to support and inform interventions. We also heard a little bit of some of the challenges. I'm not going to dwell on that, the lack of standardized data, the lack of quantity of data that is available to develop different types of models. There were obviously different models described and how they have been implemented. There was also mention of collaborations between different skills and different experts and bringing together the different stakeholders. This was really amazing. And because you did an amazing job sticking with time, I think we have time for a few questions from the audience. We can start in the middle, then go to the right and to the left. If you can come forward to get the microphone, that would be great.
This is Lydia from Colombia. Thank you very much for your presentations. I've been sitting here very interested in what you have to say. So the data science is very valuable. The models that are produced, you have shown good examples on how valuable they are, but still they are simpler models of more complex realities. So one of the things that we have been reviewing in the literature is that they usually lack validation. What are your approaches for training the limitations of these models, and also your plans to actually try to translate these models into real life tools after good validation studies?
Anyone want to take this question? Ephraim, Durga, anyone? Yeah, go ahead.
Hi, thanks. So, totally agree with you. It's like in our case, it was really challenging to try and represent something as complex as primary healthcare, for example, in a model that a statistical methodology would be able to deal with. In fact, I don't know if anybody noticed, but I said 10 components, but actually only presented 8 because it was 10 components originally, but then just this, it wasn't working. So we had to simplify in order to be able to get some results. What happens then is, but I feel like that's what happens in research all the time. Like there's this one image I didn't bring today, but it's like massive knots of lines around and researchers in a small room trying to connect A to B with one line. Like this is what we try to do always in research, right? Simplify in order to understand. But moving from here, what we're thinking is like, okay, some interesting things have appeared, but for example, due to the complexity of our model, we weren't able to include a lot of confounders and contextual factors. So we're going to look into more detail. This planning and organization component that we found that was really important, we'll maybe study it individually, being able to then take account of, because statistical limitations are always going to be a factor and we can't just stomp our feet and decide to overcome. But that's kind of, yeah, it was a struggle to accept this, but we had to just try and simplify, find a balance, right? Between simplification and trying to contemplate all the things that were relevant. So
that's the reality of data science implementation. I saw another question in the middle, and then we can go to the, please, if you can move forward to get the microphone. Oh.
All right, thank you so much. My name is Oyewole Edeli from Nigeria. That's Institute of Marine Virology, Nigeria. So I just want to add, so just in response to our question, actually that's what I have in mind too, that the challenge with external validation in terms of bringing all this to reality. So I would suggest that you test these data sets in another population. Let's see if we have similar findings, and with that you can compare your results. Another thing I have in mind is regarding this sample size, the data size. I noticed that is small, that's for you. That's quite small actually for testing and training. I just want to know, do you do what we call consider parsimony, where we consider the parameters that are lesser or fewer in number to be sure that we have the predictive model? Thank you.
Could you please repeat the question?
I couldn't hear the question, I'm sorry.
Let me just simplify here. What I'm trying to say is when you have a data size that is small in number, you want to consider parameters that are also fewer. That's the concept of parsimony. So in that case, we say less is better. And by so doing, you have more kind of a model that is more predictive rather than generalizing. So I just want to know whether you consider that when you do your testing and training.
Yeah. So we try to reduce the number of features because the sample, the data samples we have is less. That's what you want to come at, right? Yeah. So if we had maybe a larger data, we could use techniques like, more advanced techniques like neural networks and so on for building the prediction models, because the number of features were, quite okay, quite decent. There were around 20-25 features. So if the number of samples were more, we could use more advanced techniques. But maybe again, addressing your point as well. So sometimes it's better to keep things simple in order to interpret the model more. And that is what we essentially want to do in case of clinical settings, that if you try to see every person is different, so then you would need a different model for every person in that sense. But when you're trying to generalize things for the whole population, I think it's better to keep things as simple as possible and use the simplest models so that you are able to interpret the results in a better way.
I think there was a question here. If you can come forward.
Good day. My name is Victoria. I work as a data analyst at the Institute of Human Virology, Nigeria. So I think this is my best session yet, because everything has been over, but this one, I'm able to relate with everyone, and great job to all the speakers. So the first question is to, sorry, I don't know your name, from Brazil. So I just wanted to ask how you were able, what techniques you used in linking data sets in your study. You did talk about how you linked up to about 6 or 7 data sets. So where I work, it's difficult for us because you have data in silos, and the challenge is that these data sets do not have a common unique identifier. And linkage, I have been struggling with that for almost the past 6 months. Linking those data sets is a huge challenge. So most times they're only able to show the data in aggregate formats. So you are just saying this has this, this has this. So how did you deal with that? I know you have population size cohorts. Unfortunately, we don't have that where I come from. So the second question is for Professor Nicola. Yeah, I know IHVN works with you on I have the H3 Africa project and also the Inform Africa, that's DSI Africa, just to ask if the training institutes would be, that's data science institutes would be degree awarding, if you have those plans, whether they'll be degree awarding and where they'll be located. I know the projects are scattered across different countries in Africa, if they would be just in South Africa or across those project sites as well. And for the doctor from Malawi, I'm sorry if she's not from Malawi. I'm sorry. Yeah, you said, VLS, yes. HIV, sorry, sincere apologies. Just to ask, you found that viral load suppression was lower in children using the DSD model, but just wanted to add that as compared to those in other facility-based models, just wanted to ask if that difference was statistically significant or it was just lower if you did a proportion test to know if it was statistically significant. Thank you.
All right, I think we got a good combo here.
Oh, okay, I said for the, you said that viral load was lower in children within the differentiated service models as compared to the facility-based models. Just to know if that difference in proportion was statistically significant, if the p-values were lesser than maybe a set threshold, or they were just, you just stopped at the descriptive part of things. Thank you.
Christine, do you want to start?
All right, thank you, Victoria. For children was significantly low, and it was observed from the results. And one of the main reasons why they were really affected, in most cases, I believe we can all attest to this. If you're giving psychosocial support, usually focus on the older children, we focus on the adults, and we hardly think about the little ones. So as we were enrolling some of them in the DSD models, even some of their parents actually didn't even know what it was all about. So at times people, yes, they're suppressed and they're pushed to do things when they're not even aware about the whole idea. So at some point it significantly affected quite a number of children, and they had their viral loads, not suppressed as compared to the rest of the other older children and the adolescents. Yeah, thank you.
Valentina, you go next.
Hi, thanks a lot. Oh, where'd she go? She disappeared. Oh, hi. So we work in a center.
I know this is a complex question.
Sorry?
Try to answer this question briefly. I know it's a complex.
Sorry. Super briefly. Myself and my team as mere researchers, we just did a bit of merging for the last little bits of not the individual level data. We have like data specialists that take individual data and they use like a whole lot of very special techniques to link them. And I'd love to talk more about this. So let's exchange contacts. But, and if we can support, I think we would love that as well. So I'm not going to delve into that detail because Amel got scared.
It's going to take us another hour otherwise. Nikki.
So on your questions about the Institute, it will be continent-wide. We'd obviously build on H3 BioNet, but also other networks. So the African Open Science Platform has in its plan a data science institute. African Biogenome Project now wants to do an institute. So it'll be quite widespread and quite diverse in terms of the research areas. We wouldn't focus immediately on degree programs because that is the remits of universities, and we've looked at accreditation across different countries, and accreditation and recognition of credit-bearing courses is differing across African countries. So that's a big hurdle to get over. So we'd start with short-term training, professional development training, and then think about degrees and supporting that later.
Great, thanks, Nikki. I think because we had 3 questions in one, we're just going to wrap up. And I wanted to ask all of the panelists if they can share one recommendation based on your work on how to maximize the impact of data-centered findings in 20 seconds. We'll start with Christine.
All right, thank you. I will strongly and courageously encourage all of us to focus on psychosocial support. For me, from my findings, this is an area where most of us neglect and we assume people know what they do. But as a health worker, as a psychosocial person, as a community health worker, in whatever, cadres you are, it's very important to make sure that the people you're working with, you're talking to, know what you're talking about, they understand, they've understood what you're telling them. Psychosocial support goes beyond telling someone, take your drugs, do this and this, but also finding out they understand what you've told them, they're okay, their lifestyle is okay, like going beyond the common things we know. It's part of healing and it's part of health. So let's not forget that. Let's encourage that and let's work to make sure that it's done. Thank you.
Christy?
Yeah, one takeaway point I want to say is it's women and women needs to be empowered. The second one is we have to look at the cultural and traditional values. Each one we value and we own a culture and tradition. So I think it's when we look at a group, we have to value what they believe and we have to go along with the flow. There's a saying that when you're in Rome, become a Roman. So when you're with the group, you have to become one among them to get them. So we have to respect the culture, we have to respect the tradition so that they will get the benefit of the health outcome. Thank you.
Ephraim?
Thank you. For me, I think irrespective government collaborating with other sector in management of adolescent pregnancy is a key. And also as individual, we should also collaborate with others to learn from each other on data sets. Thank you.
Durga?
So I think in very short words, I think data is everything. So there's a lot of information that data hides in itself, which represents the things going on around in the true world, in the real world setting. So it is important to trace back and think where the source of the data is coming from, rather than only focusing on applying different new machine learning things or new techniques. So if we go back and focus on understanding the data better, I think we can apply, we can build models that that can be applied to the real world.
Valentina?
Yeah, so I think we've seen what the power and the potential of administrative data collected by the government is. So collaboration with these governments is super important, especially for creating current knowledge, right? So as you may have noticed, the dates of a population were kind of old, and that's due to the process of obtaining these databases. So close collaboration in order to expedite this and have more current knowledge would be really great.
Nikki?
Okay, so the social and cultural things have been covered, so I'll focus on the data. We used to have an environment where we were data poor but information rich. We're now data rich and information poor. And the data, whatever we do with data, it's nice to play with it, but we need a real outcome. So we need to be working with data because we want to generate knowledge, or we want to work with data because we want to generate a product, or we want to benefit a patient. So let's have a real research question. Let's have a real reason to work with that data and do it responsibly.
Thank you all. Collaborations, who benefits from the evidence, think about the context, bringing the different stakeholders together. We have a lot to do. Thank you, everyone.